Hi, this is Dr. Max Fung, University of California, Davis in Sacramento, California. This is the annual introduction and orientation for our year-long teaching curriculum in dermatopathology. For our dermatology and pathology residents, Derm 470 medical student rotators, visiting scholars, and other observers. All dermatology and pathology residents should have received the welcome handout from me containing a description of our lab and teaching curriculum with names and contact information for our 3 full-time dermpath faculty and team of over a dozen admin and laboratory staff, couriers and billers, as well as grossing guidelines for skin specimens. We follow a 12-month curriculum that commences each July with a series of 3 introductory lectures, starting with this one, followed by study of common skin disorders, special stains, and patterns of inflammatory skin disease. For the dermatology residents, and for that matter any trainee interested and available, these lectures are followed by a second hour of unknown slides on the same topic. Additional teaching sessions include a monthly board and biopsy review session, monthly inpatient clinical pathologic correlation or morbidity and mortality conferences, and also presentation of dermpath material for all patients presented at our twice-monthly dermatology grand rounds and monthly multidisciplinary conferences focused on advanced cutaneous malignancies and pediatric lymphovascular disorders. This year should be an interesting year, since the dermpath lectures are going to be delivered to you in 3 different formats: pre-recorded, like this one, from me, in person, such as shown here with Dr. Mark Silverstein moderating our grand rounds, and Zoom. However, Zoom remains the common denominator for all 3 venues. For my recorded lectures, I will be available on Zoom to answer questions and discuss. And for in-person lectures here in the dermatology department from Dr. Maya Kiyuru, a hybrid format will allow all of the pathology residents to participate. And the reason I think this year will be interesting is that trainees and educators have appropriately wondered and struggled, each with only their own anecdotal experiences, over which teaching methods, if any, might be superior. Each approach has pros and cons, and those may differ for trainees in different situations or with different learning styles. But this year, you'll get a chance to hear the same or similar material presented in different ways, and I'll be interested in hearing the feedback at the end of the year. Having given this introductory lecture every year for over 20 years, in my older age now, I find myself feeling mildly nostalgic for the old days when all residents gathered at 8 a.m. in a single conference room. During this first lecture, we would go around the room introducing ourselves one by one, acknowledging that any derm resident might be paging any path resident at 3 a.m. for a stat frozen section, or any path resident someday in the future chapter of life might be reading most of the biopsies submitted by a dermatologist in this room. And while I'm sure that not all of you wish you could do that now, since I should have your attention for a moment, I'm not going to squander the chance to introduce you virtually. And this is also your chance to find out that I need some gentle guidance on how to pronounce your name. So in the pathology department, and I've updated these PGY numbers from the website, we have Dr. Alex Chow, we have Biki Chuluunerdene, Lorene Chung, Marshall Ellison, Heather Green, Melissa Ha, Sarah Hoffman, Yudin Pemba, and Aresh Saha, with Aresh and Melissa serving as chiefs. And incoming first years, I've only met some of you: Dr. Connie Chang, Juliana Bogert, Isagul Uzlu, and Shafag Parsazad. Apparently in the dermatology department, whoever made this has taken more of a hierarchical rather than alphabetical approach. But for our senior residents, we have Drs. Alana Breen, Bridget Myers, Alyssa Ortega, Liz Ortega, Anita Savell, and Atrine Tusi, with Ilana and Bridget serving as chief residents. In our PGY3 class, the second years, we have Dr. Samantha Daniel, Josephine Hai, Alexander Alec Ho, Tracy Ngo, and Jeffrey Rajkumar. And our new first years, PGY2s, having survived internship, include Drs. Joyce Chen, Ted Jacoby, Laney Simmons, Samuel Stetkovich, and Danielle Yee.
So, dermatopathology, or some say dermatopathology, or just dermpath. It's a relatively subspecialized area in medicine that is dedicated to the evaluation and management of skin disease via the microscopic and increasingly submicroscopic evaluation of lesional skin tissue. And it's a fund of knowledge that was created jointly through the efforts of pathologists and dermatologists
About a century and a half ago, and in order to do an authentic history dive, one needs to be able to understand some European languages. Poring over relatively ancient textbooks gifted to me by the late Dr. Peter Lynch, it's apparent that the likes of Curley, Pincus, and Paul Una, among many others, figured largely in the foundation of the clinical and subsequent histopathologic funds of knowledge that still form the basis of dermatopathology in the 21st century. I particularly remember Dr. Paul Una since I have a photograph of him on the wall in my office just above a piece of the old basketball arena that the Sacramento Kings used to play on. During Dr. Una's time in the late 19th and early 20th centuries, he was regarded as among the very top dermatologists in the world. Trained in Vienna and practicing in Hamburg, he was the first to describe the stratum granulosum, the first to describe seborrheic dermatitis, originally known as Una's disease, also acanthosis nigricans, and one variant of congenital pattern nevus, Una's nevus. Probably his name comes up most frequently in modern dermatology clinics when an Una boot is prescribed. My own experience in dermatopathology, limited to the English language, can be traced to textbooks of dermatopathology by Dr. Walter Lever. This is the first edition. I think this is the original in my limited knowledge as a dermatology history dilettante, emphasis on dilettante, the original comprehensive US-based dermatopathology textbook written by Dr. Lever when he was a fifth-year dermatology junior faculty at Harvard in 1949. And I believe Lever's dermatopathology remains the most comprehensive US-based dermatopathology textbook now in its 12th edition. And at this juncture, I feel compelled to mention a scholarly point of pride, if not conflict, not financial, unfortunately, a scholarly point of pride in that I co-authored one of the chapters in Lever. And in the framed photograph, Dr. Lever is standing in the center when he visited in 1977 as UC Davis Dermatology's Novi Visiting Scholar. Standing to Dr. Lever's right is Dr. Lawrence Bass, Larry Bass, the founding chair of our dermatology department. I'll talk more about tissue staining and special stains in that intro lecture, but suffice it to say here that the accidental discovery of hematoxylin as a tissue stain in the 1800s, followed by the creation of eosin, and soon after the discovery of the hematoxylin and eosin, or H&E double stain, revolutionized the field of pathology and essentially formed the foundation of anatomic surgical pathology as we know it, including dermpath. And it would be a vast understatement to say that this technology has stood the test of time, like a century and a half, and still going strong. I attribute the longevity to a winning combination of its superior ability to discriminate fine details within tissue specimens, combined with its rapid turnaround time and cost effectiveness. So in rendering a diagnosis on case after case after case, pathologists wield great responsibility and power, and that is par for the course in traditional surgical or anatomic pathology, AP, where histology is the diagnostic gold standard for most tumors, including skin tumors. Clinical correlation is still essential, and of course, with any technique, there are limitations. So some cases are simply challenging and beyond the range of what H&E can resolve. Alternatively,
If one is perhaps asleep at the wheel for even just one case, there's a potential to make an error that could potentially result in patient harm. Sometimes a technical error could be quite significant, a wrong or a switched specimen. And then finally, we mentioned ancillary diagnostic testing, which can be decisive in certain cases, but typically the decision to test has to be recognized as being indicated based on the H&E. The 1970s and 80s saw rapid adoption of immunohistochemical stains, or IHC, as an ancillary diagnostic test, and in many cases essential for diagnosis. And we're now seeing increasing reliance and availability of molecular diagnostic testing. And molecular studies are playing an increasingly prominent role in the entire field of pathology. It's been said that such studies may even replace H&E entirely within the next few decades. This being a quote and also a photographic tribute to the first person who taught me dermatopathology as a second-year medical student and then later as a dermatology resident, Dr. Phil Lebois, founder of UC San Francisco Dermatopathology Service. The other side of dermatopathology are the skin rashes, or inflammatory skin disorders, in which the gold standard for diagnosis is not just the pathologic diagnosis, but rather a clinical path correlation. So one must know one's clinical derm. Although dermpath and H&E have been around for well over a century, the subspecialty is still relatively small in terms of full-time practicing dermatopathologists. UC Davis Medical School was founded in 1966, and it was not until '86 that Dr. Ronald Barr was recruited as chair of dermatology with a primary focus in dermpath. Joining him was the late Dr. Philip Vogt, who stayed here for the rest of his career. After that, we had the amazing Dr. Beth Rubin. I arrived in 2002 and started the dermpath service as we know it today. And of the 7 full-time dermatopathologists at UC Davis, 3 of them are still your attendings, myself, Dr. Thomas Konia, and Dr. Maya Kiiru. We also have an affiliation with the Veterans Affairs Hospital, where we have Dr. Joshua Schulman, an amazing teacher. We also have volunteer teaching from dermatopathologists in private practice at Diagnostic Pathology Medical Group. And there are many dermatopathologists who are board certified but not primarily focused on dermpath. One of those is Dr. Peter Lynch, former department chair and distinguished Novi professor and program director. And Dr. Lynch was the one who kindly donated some of his older dermatopathology textbooks to me when he retired. The UC Davis Dermatopathology Service is a CLIA certified and CAP, College of American Pathologists accredited laboratory within the Department of Dermatology, located a few miles from the main UC Davis Hospital and Medical Center at the site of an old cannery, now Cannery Business Park, or the Park, in East Sacramento. Across the street is the Roxy Delicatessen, which was featured in the 2017 film Lady Bird. Skin specimens are obtained and submitted by a wide variety of healthcare providers, but the single biggest source, of course, is the dermatologist's office. This is an example of quite a large waiting room. This is Peking Union Medical College that I had the opportunity to visit in 2018. The dermpath waiting room is quite a bit more compact. And sometimes I tend to rather fancy ourselves as more of like a 5-star hotel or a Medi-Spa, in that our dedicated couriers diligently and carefully and safely transport each specimen from its site of origin and delivers them to their appointment in the dermpath waiting room. One by one, each specimen is accessioned, grossed, processed, embedded, cut, stained, cover slipped, labeled, and magically slides appear in trays on our desks. And we subsequently then view these alongside trainees in many cases and then issue a diagnosis in the form of a pathology report.
If you walk in the door and you see this big sign, you know you have arrived. Heading further inside the dermpath suite, our old school educational workhorse is an 18-headed teaching microscope primarily used for daily afternoon teaching sign-out, with all rotating dermatology and pathology residents, as well as rotating medical students, visiting scholars, and other observers. This is also our primary microscope for interpreting direct immunofluorescence, or DIF studies. And I wonder if this might be the only DIF setup on an 18-headed microscope, much less any multi-headed microscope, in the entire country, if not the world. If you know otherwise, please comment below. As of the May 2023 ending of the COVID-19 global health emergency by the World Health Organization and end of the public health emergency by the CDC has regarded the risk of surface transmission to be generally low, but with COVID intent on continuing to make itself known from time to time and still potentially quite disruptive, disabling, or even deadly, it's prudent to keep in mind the hygiene and distancing considerations that were so rigidly enforced in the early days of the pandemic. Currently, there are no distancing restrictions, and in-person sign-out has been the norm since 2023, with Zoom as a backup. What we have found out is that hybrid sign-out, meaning some trainees at the microscope and others following via the microscope camera as a Zoom screen share, is both technically challenging and suboptimal.
And here is a closer view of the microscope itself, and just a reminder of the typical touch points on the microscope. We have the objectives on the turret that are handled, and then the slide being pushed with or without a slide holder on the platform. We have the focusing knobs, the subcondenser handles down here somewhere, and then also the eyepieces as the most frequent touch points on the microscope.
Next to the big sign at the entry, our new school educational workhorse is a digital whole slide scanner that we now use for teaching archives, tumor boards, as well as research and remote clinical coverage. Our dermpath service uses two different lab reporting systems. For UC Davis cases, we have the Beaker lab reporting system, which is part of the EPIC EHR. And then for outside cases that come from outside UC Davis, we have a separate system supported by Novopath. Now for these two laboratory reporting systems that run in parallel, trainees will essentially only be using the first system, which is the Beaker lab reporting system that is electronically interfaced with the EPIC electronic medical records. And so all specimens submitted by UC Davis providers will be in this system and use a DC accessioning wheel in contrast to the SP accessioning wheel for cases that originate in the hospital pathology laboratory. And for cases submitted by providers outside UC Davis, we use the Novopath system with a DS accessioning system. I feel very blessed that I've worked consistently with very conscientious and responsible colleagues and trainees. The one housekeeping thing to remember is that these little 1 by 3 inch glass slides are easy to move around, but just remember that they're part of the patient's medical record. And unlike the electronic records, they are essentially irreplaceable. So if you do need to take slides out of the dermpath unit for whatever reason, please just check in with our admin staff and they can prepare a tissue release form for you. All of the recent slides from the past several years are filed on site, and so you could retrieve those yourself or ask one of our very capable admin staff to retrieve those slides for you with a little bit of advance notice. And when you're finished with the slides, you don't need to refile them. Just go ahead and put them in this shelf around the corner from the main admin desk. And it is a point of great personal pride that I can speak with total confidence that every one of our administrative staff on the front lines and lab staff in the back of the house, so to speak, takes great pride and responsibility for their own expertise and ability to provide the very best support for our patients and their providers. And it's also totally obvious to me that we could not do what we do or accomplish what we have without the combined and coordinated talents and efforts of our laboratory supervisor, Aubrey Gasper, and practice manager, Daniel Gong, along with their administrative and laboratory teams. Dan having been with me since inception of the service in 2003.
Biopsies obtained from critically ill patients are marked for top priority, and it never hurts that if you write or mark on the comment section of the order that it's a rush or hospital case, but our laboratory staff is well trained to recognize those specimens, and we will automatically prioritize those. Now, if you happen to be in the lab, if you are able to kind of just give the staff a verbal heads up as you're dropping the specimen off in the bin, that never hurts. And if you're off-site and need to contact the lab, you can always call the main number or get the backline for the laboratory from the orientation handout and call the lab directly to make sure that someone's going to be there. For example, if it's getting close to 5 p.m. on a weekday. And for number 3 here, I'm going to emphasize this because you're getting a lot of information overload in July of the first year especially. And once you're on the front lines and it's a critical situation, you're doing hospital biopsies, it's late in the afternoon typically when you see those patients, and maybe you decide you need to do a biopsy. So one of the things that commonly comes up with the hospital biopsies is infection. And of course, the patients tend to be critically ill. So one of the options that we have is to pre-order special stains for pathogens or bug stains. And so if you write rule out infection on the order, pretty good chance that our histotechnologists are going to recognize that and contact the pathologist of the day to make a determination if special stains should be obtained. But in the end, it's kind of a case-by-case decision. On one hand, sometimes you look at the H&E afterwards and realize that the special stains were never indicated. But on the other hand, if the index of suspicion is correctly high, then we are going to want those special stains to be more definitive about confirming or excluding a pathogen. And of course, this is most critical on a late Thursday or a Friday or before a long holiday weekend. So all those kind of factors have to kind of be considered in the overall composite assessment and the situational awareness. But this is something to keep in mind, that we do have the capability of pre-ordering special stains when there's a reasonable chance that it is going to be fruitful. Weekend and evening stat frozen sections are covered, and they're actually covered 24/7 as needed by the Department of Pathology. The pathology residents should have the details in their resident policy and procedure manual. And this introductory lecture, when it was in person, used to be the first chance that you would get to see the people that you'd be working side by side with in the evenings or after hours when you had a stat case. Now, sometimes when a stat case happens during normal business hours and dermpath is open, we're happy to handle that stat frozen section as well. Just call dermpath, and more often than not, we'll be able to take care of that slide preparation. Your welcome packet includes a dermpath grossing manual at the end. And in that, you'll see that the shave, punch, and excision specimens are the most common specimens submitted in dermpath. The shave and the punch biopsies are relatively small specimens that can usually fit in a single cassette on a single slide, whereas the excisions and occasional incisional biopsies are usually submitted in multiple blocks sectioned in red loaf fashion. In the old days when I was a resident, and maybe still true at other programs, the residents on rotation were expected to gross the specimens. That's not the case in our program, but it's still very valuable to understand how specimens are grossed in the lab. So if you have interest in seeing that, just please contact one of your attendings and we'll arrange for you to observe one of our grossing technicians. When you're on the dermpath rotation, you spend most of your time at the microscope, so sometimes it almost seems like the slides just kind of magically appear there. But in fact, there's a lot that goes on behind the scenes, not just the grossing, but several steps after that. So this text here is just a little bit of a snippet from the grossing manual that's been provided to you, and it just attests to the fact that there's a critical importance of accuracy at every step along the way. Specimen after specimen after specimen. We have a team of highly skilled technicians working, sometimes it seems nonstop behind the scenes to get these slides to us promptly and accurately. Hats off to them.
more snippets from the grossing manual that I won't dwell on since you have it. Although I have to say, looking at this, that I do see some of the words of wisdom from Dr. Philip Lebois from UCSF. He gave me a similar grossing handout when I was a dermatology resident there. Punch biopsies may be in a wide range of diameters. Probably 4 millimeter is the most common, but as you can see, there's a wide range. Whenever possible, we do prefer to bisect the specimens so that we don't lose any tissue and that the initial sections will be from the center of the specimen most likely representative. Grossing guidelines for shaved specimens are similar to the punch biopsies. Shaved specimens could be shave removals or shave excisions, in which case we would typically add ink to better assess margin status. The glass slide on the upper right shows breadloaf sections of an excision specimen. You can see the tumor at gross power in the top two pieces of tissue there. And the grossing diagram shows a top view of an excision specimen with the vertical black lines indicating the locations of the breadloaf sections. Typically, we put the excision tips in a block, and as you can see, B and C would be a second and a third block of this specimen. If the specimen was submitted with the orientation, such as a suture or a hash mark, then we would use two different colors of ink in order to preserve that orientation in the event of a positive margin. And less commonly received is the incisional biopsy, but it's worth mentioning here. These specimens may be an identical size and shape to an excision specimen, but in this case, the clinician is not looking for margins. It may be a portion of an inflammatory disorder, often a paniculitis or morphia. And so in that case, we don't need breadloaf sections. We don't need ink for margins. What we want is really just the best tissue sections that we can get. So these would actually be sectioned longitudinally so that we get single large tissue specimens as opposed to multiple breadloaf sections. Makes for pretty viewing and nice photomicrographs in the event of publication. Let's start to conclude with a few comments on your learning. Of course, you'll be continuously training through the DermPath curriculum through your residency time here, but let's start with some of the resources that are available. And hopefully to you as digital natives, you won't find the potential for information overload here quite as whelming as a digital immigrant like me would. There's no shortage of dermatology, pathology, and DermPath textbooks. Some of the ones listed here are just scratching the surface. Increasingly, as you can see here, some of these resources are online, and pretty much all of these textbooks generally nowadays have online versions for you to study from. And as I alluded to before, unfortunately, I do not have any financial conflicts of interest with any of these. I did write a few chapters in some of these books, but that's the extent of it. And currently, our program is providing the Elston and Faringer textbook here, this one right here. And so that's what the dermatology residents are starting with. But I find that many trainees over time then expand to other textbooks, depending on your level of interest. Social media, fueled by the pandemic, resulted in a veritable explosion in the past few years of online educational resources for learners of DermPath, and fortunately most are free, beyond the precious cost of your time to view them, of course. Social media influencers and educators like Jared Gardner have helped me and many others adopt Twitter, now X, for international journal clubs and meeting tweets. However, it was my then 10-year-old daughter Caroline who, in the spring of 2020, when all DermPath education had gone virtual, she started her own secret YouTube channel, not secret enough to inspire me to start recording and publishing my lectures, though. This list of online DermPath resources published in 2023 shows that, indeed, YouTube seems most prevalent, although a variety of others platforms are active, notably Kiko, as well as courses including board review courses, consistent with the fact that the construction of a complete comprehensive online dermatopathology curriculum is now a reality, and in fact such a curriculum has been published by Eisenson, Mukosera, and colleagues. If you find yourself wanting to learn more about DermPath, perhaps even a possible fellowship application, or potential DermPath-focused career, it's a good idea to move promptly to the cutting edge of the field by staying on top of the literature and consider submitting material to present at the meetings and possibly also then publish. Among the three major dermatopathology journals, the American Society of Dermatopathology, ASDP, and International Society of Dermatopathology, ISDP, organize 1 or 2 meetings annually. In terms of my own involvement, I have served as a manuscript reviewer for all 3 journals and also serve on the editorial board for Journal of Cutaneous Pathology, the journal of ASDP. Within ASDP, I also currently serve on the social media subcommittee, chair the appropriate use criteria committee, and was also fortunate to be the nominee for their upcoming leadership cycle.
I think I've had some version of this slide in my introductory lecture probably for at least a decade. But I like to put this up at the beginning of the year because we have incoming trainees and also trainees who are graduating to the next postgraduate year. And I think it's an appropriate time as any to think about yourself, think about your training, your goals, your aspirations, and see how that might fit, whether that be dermpath or some other area of dermatology or medicine. But here's some details of what could be construed as a hierarchy of competence in dermatopathology. And of course, I put a question mark there because there's not a whole lot about this that needs to be rigid. One could say very little about this or discuss it for hours. So that will happen in the Zoom session afterwards. But at a minimum, as a dermatology or pathology resident, you are expected to pass the dermatology or AP boards. And as you surely know, the dermpath component exists in both. So that's the minimum. Everything else is extra on your own, but there's lots of different things that can be done. If you complete a fellowship, then it opens up other opportunities. These are things that we can discuss individually or as a group in the Zoom meeting. And as we segue to the virtual discussion, I'm going to leave you with 4 scenarios to think about and discuss with me. I won't read them. You can look at them as fast or slow as you want. But here's the first one. Here's the second one. Here's the third scenario for discussion. And a fourth scenario. And finally, the last and perhaps most philosophical one. So I hope you found some useful information and resources from this introduction. Your dermpath attendings here are very passionate about telling, showing, and involving you in the wide world of dermpath. And we know that you'll forget some things, but also that you're going to remember and learn.